Welcome to the deep dive. Today, we're really focusing in on uh, a crucial area, but one that maybe doesn't get as much airtime. The arteries of the upper extremity. Arm arteries, basically.
That's right. Leg issues, lower extremity problems, they tend to grab the headlines. But issues in the arms, they can be just as serious, sometimes even more complex in their own way.
And for this deep dive, we're tackling Rutherford's vascular surgery and endovascular therapy, specifically chapters 120 through 122. The idea is to pull out the core essentials, right?
Exactly. Think of it like we're creating a condensed instruction manual for vascular surgeons dealing with upper extremity arterial disease. All the key stuff from those chapters, synthesized.
Okay, a concise guide from Rutherford. I like that. So what's our roadmap? How are we breaking this down?
Well, we'll start with the basics. How common is this? The epidemiology. Then we'll get into the why, the different causes, the etiology, and how these diseases actually develop.
Makes sense. Causes first.
Then diagnosis. How do you figure out what's going on? After that, we'll cover the treatments. Medical options, surgery, endovascular approaches to...
Getting the really tough situations.
Yeah, finally, we have to touch on amputation.
Yeah.
What are the considerations when that becomes, unfortunately, necessary? So really the whole spectrum.
Got it. A comprehensive toolkit. Let's start with that first point then, prevalence. How often are we actually seeing these upper extremity issues? Chapter 120 territory, right?
Right. And the first thing to grasp is it's relatively uncommon compared to the legs. We're talking at less than 5% of all evaluations for limb ischemia. That's pretty low.
Less than 5%. Wow. And the causes are different too, aren't they?
Hugely different. In the upper extremity, the main drivers are often autoimmune conditions, connective tissue diseases. That's a stark contrast to the lower limbs where, atherosclerosis is king.
That really is a fundamental split. Wasn't there a Dutch study mentioned that supports this?
Spot on. Yeah, a key Dutch study showed much lower rates of abnormal Doppler findings in the arms in both diabetic and non-diabetic folks compared to their legs. Really drives home that different pattern.
Okay. But there's one condition that seems much more common up there. Raynaud syndrome.
Ah, yes.
Yeah.
Raynaud's is the exception to the low prevalence rule. It affects a good 3 to 5% of the general population.
That's quite a jump.
And it gets even higher in colder places.
Right.
Up to 20, even 30% of people in cold climates report that cold-induced finger pain or color change associated with Raynaud's.
And it's not all the same, is it? There's primary and secondary Raynaud.
Crucial distinction. Primary Raynaud is sometimes called Raynaud disease. We basically don't know the underlying cause. It's idiopathic.
Okay.
But secondary Raynaud's or Raynaud phenomenon is linked to some underlying problem, often an arterial issue or systemic disease. And that's important because secondary Raynaud's has a higher risk of progressing.
Progressing to what?
To more severe occlusive disease, potentially leading to constant pain, ulcers, even tissue loss of the fingers.
So what are those underlying conditions we see with secondary Raynaud's?
The big ones are connective tissue diseases. Think Scleroderma, mixed connective tissue disease, MCTD, lupus, SLE, rheumatoid arthritis.
And Scleroderma is particularly common.
Yeah, Scleroderma is the most frequently associated connective tissue disorder. And what's really important for clinicians, for you out there evaluating patients, is that Raynaud's symptoms can sometimes show up months, even years, before the systemic disease itself is fully diagnosed.
That's a key clinical pearl. Okay, let's dig into the why, a bit more the etiology, the pathogenesis. How does Chapter 120 break this down?
It uses a helpful framework. It categorizes things based on vessel size, large versus small, and the nature of the problem. Is it vasospastic, like a spasm, or occlusive, meaning blocked?
It's full enough.
Generally, vasospastic issues tend to hit the smaller vessels, like in the fingers. Occlusive diseases are more likely in the larger arteries, further up the arm.
So Raynaud's clearly fits that vasospastic small vessel picture.
Exactly. The defining feature is that vasospasm temporary narrowing of the digital arteries. It's triggered by things like cold, stress, sometimes even caffeine, leads to that temporary lack of blood flow.
But the arteries are okay otherwise.
That's the key for primary Raynaud's between episodes. The baseline pressure in those digital arteries is usually normal. Now, why it happens is complex. It involves the sympathetic nervous system, the vessels themselves, changes in receptor sensitivity, various vasoactive chemicals. It's multifactorial.
Okay, understood. So what's causing the occlusive diseases in the arm then? The blockages?
Well, atherosclerosis is still a player, just less dominant than in the legs. Plaque buildup.
Right.
Other major causes are thromboembolism clots traveling from elsewhere, often the heart, especially with conditions like atrial fibrillation. Then there are iatrogenic injuries, problems caused by medical procedures.
Like dialysis access.
Exactly. Steele syndrome from dialysis access, or complications from cardiac caths going through the arm arteries. And finally, vasculitis inflammation of the vessel walls can also block things off.
You said atherosclerosis is less common. When it does happen in the arm, where does it usually show up?
It has a preference for the big vessels coming off the aorta, the brachiocephalic trunk, and the origin of the subclavian artery.
Okay.
And here's something really practical. Even asymptomatic subclavian narrowing can matter. If you find a blood pressure difference of 15 millimeter Hg or more between the arms, that's a sign of possible subclavian stenosis, and it's linked to higher cardiovascular mortality risk and more peripheral vascular disease overall.
So check both arm pressures, always.
Absolutely. And of course, the usual suspects for risk factors apply here too.
Mm-hmm.
Smoking, high blood pressure, high cholesterol, diabetes. Same as for PAD anywhere else.
Got it. Chapter 120 also zooms in on the small vessel problem, the arteriopathies. These are happening distal to the wrist, right, in the hand and fingers.
Precisely. And like we mentioned, autoimmune and connective tissue disease are really the main culprits here, often causing pretty severe ischemia in the hand and digits. Scleroderma is probably the poster child.
Why scleroderma specifically?
Well, it's the most common connective tissue disease linked to secondary Raynaud's. It's a systemic issue affecting connective tissue everywhere, but it really hits the microvasculature, the tiny vessels, and the small arteries. You see damage, inflammation, eventually fibrosis, scarring.
You mentioned it's more common in women.
Yeah, definite female predominance, about 3 to 1. And diagnostically, looking for certain antibodies like anti-centromere or anti-CCAL70 can be really helpful. Interestingly, the vascular damage often comes before the widespread skin thickening and fibrosis that people associate with scleroderma.
What about lupus, SLE?
SLE tends to affect younger women primarily. The thought there is that immune complexes depositing in the vessel walls cause the damage. Raynaud's is pretty common in SLE patients too. Diagnosis is usually based on a cluster of clinical signs and symptoms.
And rheumatoid arthritis. We usually think joints first.
Mostly joints, yes. But RA can cause vasculitis, rheumatoid vasculitis, affecting arteries and veins. Thankfully, it seems less common now with better RA treatments. There are genetic links, and factors like being male or smoking increase the risk. Some RA meds, like hydroxychloroquine or low-dose aspirin, might even be protective against the vasculitis component.
Okay. Next up, Sjogren's syndrome, known for dry eyes, dry mouth.
That's the one. Can be primary or secondary, linked with other diseases. Much more common in women, maybe 9 to 1. It's associated with small vessel problems, different types of vasculitis. Sometimes even a systemic vasculitis resembling polyarteritis nodosa can pop up.
And MCTD, mixed connective tissue disease.
Yeah, that's an overlap syndrome. Patients have features of several conditions, like SLE, RA, scleroderma. Raynaud's is very frequent in MCTD, along with arthritis, muscle inflammation, lung issues.
Right, so that covers the main autoimmune players. What about Berger disease?
Berger disease, or thromboangiitis obliterans. This one involves segmental blockages from clots, mainly in small and medium arteries. Legs are more common, but the arms are involved maybe up to half the time.
Who typically gets it?
Classically, young male smokers. Often you'll hear about migratory thrombophlebitis clots in superficial veins that move around and secondary Raynaud's. There are specific diagnostic criteria to help nail it down.
Hand-arm vibration syndrome, HAVS. That sounds pretty self-explanatory.
It is. It's basically Raynaud's developing after long-term use of vibrating tools. Think jackhammers, chainsaws. The kinetic energy seems to damage the small vessels and nerves over time. It can start as just spasm, but progress to actual blockage, occlusive disease.
Is fibromuscular disease, FMD, common in the forearm arteries?
No, it's actually quite rare down in the forearm, palm, or digital arteries. When it does happen, it can cause finger ischemia, maybe from little emboli or just narrowing. Some think hypothenar hammer syndrome might be related, where trauma to the heel of the hand causes issues, potentially due to underlying FMD.
What about hypersensitivity angiitis? Sounds a bit mysterious.
Yeah, it kind of is. It refers to acute digital ischemia, sometimes even ulcers, where you just can't find an underlying cause like connective tissue disease or an embolus. The theory is some kind of immune reaction against the artery wall. Usually it gets better on its own over time.
Can cancer be linked?
Yes, Raynaud's has been reported with various cancers. The mechanism isn't totally clear, likely some tumor-related immune process.
And finally, the obvious one, frostbite.
Right. Direct freeze injury, Mild frostbite can cause vasospasm, basically Raynaud's. Severe frostbite can actually damage the artery walls, leading to occlusive disease and permanent problems.
Okay, that's a really thorough tour of the small vessel issues. Let's switch gears now to the large vessel arteriopathies, still in Chapter 120.
So for the bigger pipes, atherosclerosis is the most common culprit, driven by those same risk factors we already talked about. The most frequent spot is the origin of the left subclavian artery.
And there's a link to leg problems.
Definitely. A fair number of patients with lower extremity PAD, maybe 6–10%, also have subclavian stenosis. It's important to think about both.
What else affects the large vessels?
Aneurysms, bulges in the artery wall are rare in the subclavian or axillary arteries, but they can happen. Chronic trauma, like from arterial thoracic outlet syndrome, can cause subclavian narrowing and send clots down to the fingers.
Any inflammatory conditions hitting the big arteries?
Yes, Takayasu arteritis is a vasculitis of the aorta and its main branches. If it hits the subclavian, you can get arm ischemia. Giant cell arteritis, GCA, usually likes the temporal artery, but it can involve upper extremity arteries too.
What about sudden blockages in the large vessels?
Emboli are common. Clots traveling, usually from the heart due to AFib, often lodge in the brachial artery. That's the most common spot.
And problems from procedures?
For sure. Access-related hand ischemia, ARHI, can happen after dialysis access creation, especially using the brachial artery. And iatrogenic injuries damaged during procedures like catheterizations are seen more often now, with radial and brachial access becoming common.
Any specific risks there?
Well, a hematoma after brachial procedure can compress the median nerve, causing nerve problems. And while radial artery occlusion can happen after caths, maybe 1/10% of the time, the hand usually does okay because of good collateral flow from the ulnar artery and palmar arch. That's why the Allen test beforehand is so critical.
Wow, checking that collateral flow.
And one last thing, vasopressors. In really sick patients in the ICU, the drugs used to keep blood pressure up can sometimes constrict vessels so much they cause digital ischemia in the fingers and toes.
Okay, that covers the range of potential problems. How do these patients actually look when they present? What are the clinical findings?
You often see a difference between acute and chronic presentations. Acute ischemia, sudden lack of blood flow, is more common in older women. Often it's an embolus from the heart or trauma or an iatrogenic injury.
The classic
Yeah, you might see the classic signs: pain, pallor, paleness, pulselessness, paresthesias, numbness, tingling, paralysis, and poikilothermia, coldness. But crucially, the arm has great collateral circulation, so actual tissue loss is pretty rare, and limb salvage rates are high, maybe around 98%.
And chronic ischemia, what does that look like?
That usually shows up as muscle pain with use like arm claudication or non-healing ulcers on the fingers or hand, or even gangrene in severe cases. The arm might look okay at rest, but you might feel coolness, and the pulses at the wrist or elbow could be weak or absent.
What about that access-related hand ischemia, ARHI?
Symptoms there can vary a lot, but one useful trick on exam: compressing the dialysis fistula often makes the wrist pulses or Doppler signals better, which points towards steel physiology.
So history and physical are absolutely key. What about the next steps, the more specialized diagnostic tools? Chapter 120 details the workup, right?
Absolutely. The clinical evaluation is where it starts. You need a detailed history, cold sensitivity, any symptoms suggesting connective tissue disease, dry isthmus arthritis, history of trauma or procedures on the arm, repetitive activities, occupational vibration exposure, all crucial.
And the physical exam?
Needs to be done in a warm room. Compare those brachial blood pressures. Remember that 15 or sometimes we say 20 millimillar G difference being significant for subclavian issues. Palpate all the pulses, brachial, radial, ulnar. Use a Doppler if you can't feel them, and check the palmar arch and digital arteries. Listen over the subclavian for a brute.
Don't forget the hands themselves.
Exactly. Look closely at the hands and digits. Temperature, capillary refill time, any ulcers, nail changes like clubbing or splinter hemorrhages, skin changes like sclerodactyly or telangiectasias, and a good neuroexam can pick up clues for thoracic outlet syndrome.
Okay, then you'd move to the vascular lab.
Usually, yes. Segmental pressures up the arm, and definitely finger pressures and waveforms like PVRs or photoplethysmography, PPG. This really helps distinguish large artery disease, where maybe the brachial pressure is low, but finger pressures are okay initially, versus small artery disease, where the arm pressures might be fine, but the digits are clearly abnormal.
What about ultrasound?
Duplex ultrasound is invaluable for looking directly at the large vessels, subclavian, axillary, brachial checking for stenosis or occlusion.
How do you specifically evaluate Raynaud's in the lab? Is it just the history?
The diagnosis of secondary Raynaud's is mostly clinical, yes, but we can do things like cold sensitivity testing, see how long it takes finger temperature to recover after cold challenge. Nail fold capillary microscopy is also useful, looking at the tiny vessels at the nail base. You see characteristic changes like dilated or distorted capillaries in secondary Raynaud's, but not usually in primary.
Any role for blood tests? Hypercoagulable workup.
Sometimes. If there's significant blockage or ulcers and the cause isn't obvious, checking for clotting disorders might be warranted. Things like antithrombin III, protein CS, antiphospholipid antibodies, factor V Leiden, and basic labs can help screen for underlying systemic diseases.
And if the non-invasive stuff isn't giving you the answer?
Then you might need more imaging. If you suspect an embolus, duplex ultrasound and an echocardiogram are key to look for the source in the proximal arteries or the heart. If those are negative, imaging the aortic arch and the main arm arteries, usually with CTA or MRA, is often next. They're less invasive than traditional angiography.
When would you do an invasive arteriogram?
It's generally reserved for specific situations like unexplained asymmetric digital artery occlusion, where you really need to rule out a surgically fixable proximal lesion that C-TAMBRA might have missed. If you do it, you need to visualize the whole arm, usually both sides, with the hands positioned properly. Bilateral disease strongly suggests a systemic cause.
Okay, so after all that diagnostic effort, we get to treatment. Chapter 120 gives an overview, and then 121 digs into the details, right?
Exactly. Chapter 120 links treatment to the natural history. For primary Raynaud's, it starts conservative. Avoid cold, caffeine, tobacco. If that's not enough, medications like calcium channel blockers, nifedipine, amlodipine are first line. Losartan, fluoxetine can also help.
Any others?
Others like prazosin, sildenafil, silestazol show modest effects. Bosentan is specifically useful in Scleroderma-related Raynaud's. But importantly, medical therapy is often less effective if there's actual underlying occlusive disease causing secondary Raynaud's.
Any downsides to the meds?
Well, nifedipine, for example, isn't tolerated by everyone. Maybe 20–30% of patients get side effects. And prognosis-wise, patients with both obstruction and an underlying systemic disease tend to do worse. If someone presents with ulcers already, there's about a 50% chance they'll get them again.
What about surgical options mentioned in Chapter 120?
Thoracic sympathectomy, cutting the sympathetic nerves, has been used for severe vasospasm, but the benefit might not last long-term. Some suggest periarterial digital sympathectomy, a more targeted approach at the finger level, might be better, but evidence is still evolving.
And for other conditions?
For arterial thoracic outlet syndrome, surgery usually involves removing whatever's compressing the artery, like a cervical rib, and sometimes repairing the artery itself. Revascularization, like bypass surgery, is the way to go for significant large artery blockages, aneurysms, arterial damage from TOS, symptomatic FMD, or trauma. And the good news is, upper extremity bypass results are generally excellent good patency rates, high limb salvage.
So Chapter 120 wraps up by emphasizing those key differences between upper and lower extremity disease.
Yes. It hits home that upper extremity ischemia is less common, has diverse causes, vasospastic and occlusive. Occlusive disease carries a worse prognosis for tissue loss. Vasospastic types respond better to meds like nifedipine-losartan. Sympathectomy has limits, and bypass is a very viable, effective option for occlusive disease with good outcomes.
All right, let's dive deeper into Chapter 121 now, focusing specifically on the medical, endovascular, and open surgical management details. It starts by saying treatment is complex because the causes are so varied.
That's the core challenge. It's not just atherosclerosis, like often dominates in the legs. You've got autoimmune issues, TOS, emboli, hypothenar-Hammer syndrome, and atherosclerosis. So the treatment really needs to be tailored, often combining approaches.
Even so, these reconstructions are still relatively rare overall.
Yeah, upper extremity occlusive disease is less than 5% of all limb ischemia. Arm reconstructions are maybe only 3% of elective revascularizations, even in big centers. Most common issues are actually in the palmar and digital arteries. Significant blockages proximal to the wrist are less frequent, maybe less than 10%.
And when emboli happen in the arm?
Mostly cardiac origin, about 75%. And the brachial artery is the most common landing spot, around 60% of the time. In situ thrombosis, clots forming right there, is less common, maybe 5%.
What about conservative, non-operative approaches detailed in Chapter 121?
Some patients, maybe 9–30%, are managed conservatively, usually due to severe comorbidities making intervention too risky or if symptoms are really minimal. This might involve anticoagulation, especially for acute or subacute clots.
Any other conservative measures?
Adjunct meds like calcium channel blockers, topical nitrates, phosphodiesterase inhibitors can be tried, but success varies. And the basics: Stop smoking completely, optimize heart function, avoid cold and vasoconstrictors, keep the arm warm. All important.
What about removing the clot surgically? Embolectomy?
Operative embolectomy is generally preferred for acute embolic ischemia if you're going to intervene. But you have to be aware of the risks. Postoperative mortality isn't trivial, mostly due to the patient's underlying health problems. That said, if successful, brachial embolectomy can lead to good symptom relief in about 95% of cases.
And if you don't intervene operatively?
Well, studies suggest patients managed purely conservatively often have poorer outcomes, permanent disability, reduced function, persistent claudication-like symptoms.
Okay. Now, Chapter 121 mentions endovascular treatment. You said earlier it's less common in the arms than the legs.
That's generally true. While technology is advanced, its uptake in the upper extremity hasn't matched the lower. Why? Probably a mix of things. It's less frequent overall, the causes are diverse and maybe not always suited to endo, and sometimes open surgery is just straightforward and effective.
Are there any endovascular applications?
Oh, sure. There's decent data, like from a Japanese study showing good results for subclavian artery angioplasty and stenting. But for blockages further down, axillary, brachial, radial, ulnar, most reports still focus on surgical bypass or embolectomy. You see scattered reports of covered stents for trauma, angioplasty for radiation damage, atherectomy the brachial, stenting in the radial for gangrene, but often small numbers, limited follow-up.
So open surgery remains a mainstay. Chapter 121 goes into the surgical exposures.
Yes, it provides really crucial detail on how to actually get to the arteries, axillary, brachial, mid-distal, radial, ulnar, even the interosseous and palmar arteries. It covers incision placement, handling muscles, protecting nerves, preserving veins. That foundational knowledge is critical for anyone doing these operations.
Does it detail the bypass, conduit, or tunneling?
Not in the specific excerpt we're discussing, but it does mention transbrachial embolectomy again as the go-to for acute embolic occlusion if surgery is chosen.
The excerpt also covers trauma, right?
Yes, both iatrogenic caused by medical procedures and non-iatrogenic, like accidents. It reiterates the risks with brachial and radial artery access during caths, including that median nerve compression risk from hematomas. And it covers penetrating trauma, blunt trauma, even specific things like vascular injury with supracondylar fractures in kids. A key point is that delayed recognition of these injuries is dangerous.
All right, that brings us to the final piece, Chapter 122. Amputation. A tough topic, but necessary. It starts by saying how devastating upper extremity loss is.
Absolutely devastating. The rehab, the social, financial, psychological impact, it's different from losing a leg. While amputations overall might increase, the upper extremity proportion is expected to stay stable. And thankfully, most upper extremity amputations, about 93%, are minor fingers or wrist level.
What's the main cause of upper extremity amputation? It's different from the legs, isn't it?
Dramatically different. Trauma is the overwhelming cause, 80 to 90%. Typically younger patients, 20s to 40s, mostly male. Vascular disease, the main driver in leg amputations, causes only about 7% of upper extremity ones.
What are the other causes?
Tumors are rare, maybe 0.6%, then infection, congenital problems, and iatrogenic causes like complications from catheters, vasopressors, or vascular access. So unlike the legs where it's usually PAD, ischemia leading to arm amputation is most often from trauma. Atherosclerosis itself is rarely the direct cause requiring amputation up there.
When revascularization is needed before a potential amputation in the arm, what's usually the reason?
Most often, it's traumatic injury. Second most common is probably embolization. Other things like severe Raynaud's, vasculitis like Berger's, radiation damage, those can lead to amputation too, but less frequently.
The chapter mentions insights from military conflicts.
Yeah, data from Iraq and Afghanistan showed some interesting things. While major limb injuries often needed amputation, the rate was lower for upper limbs, around 3%, than lower limbs, around 8.5%, even though nerve and vessel injuries happened at similar rates.
But salvage is often possible.
Very much so. Aggressive limb salvage, even with severe injuries, often works. And studies showed reimplantation actually led to better patient-reported outcomes than revision amputation and prosthesis. Also, sadly, a higher PTSD risk was noted in upper extremity amputees compared to lower.
What about when it's not trauma causing the severe ischemia?
Then the first step is always to treat the underlying disease aggressively. Stop smoking in burgers, deal with emboli via thromboembolectomy or anticoagulation. Sympathectomy or bypass are less common here. The guiding principle if amputation looks likely is conservatism, save as much length as possible. Allow time for dead tissue to clearly demarcate so you can do the smallest amputation needed. and definitely avoid vasoconstrictors.
Chapter 122 lays out some general principles for upper extremity amputation, starting with initial management.
Right. It's often staged, especially after trauma. Goal is maximum functional length. Not just length, but function and appearance are key in the arm. So definitive level isn't decided immediately. Sequential debridements, maybe negative pressure therapy to prepare the wound bed, then later closure. Early focus on emotional and functional rehab is vital. The strategy depends on the cause, age, handedness, job, other injuries, overall health, rehab access, even culture.
How do you assess if the stump will heal? Arterial assessment.
Crucial. You need adequate blood flow. It's a mix of physical exam and non-invasive tests. Duplex, segmental pressures, PVRs, PPGs, laser Doppler, TCPO2, sometimes arteriography. There are rough guides like digital pressure, 40 mmHg for hand healing, wrist brachial 60 mmHg, or TCPO2 or 40 mmHg for forearm arm healing. Lower values are less predictable. Sometimes, if you have good soft tissue cover, just tying off the vessels is enough.
You mentioned preserving length, but balancing it with function.
Exactly. Maximum length is the goal, but not if it compromises function or healing. Sometimes reconstructive techniques, plastic surgery, bone shortening, free flaps can help optimize this, especially in planned amputations. Elbow retention is a huge goal if possible. It makes a massive difference functionally.
And soft tissue coverage options have improved.
Massively. Used to be limited by local tissue. Now we have skin grafts, need good bed, durable, local flaps, limited, and especially free tissue transfer moving tissue with its own blood supply. This allows for better coverage, potentially preserving more length, especially more proximally.
Managing nerves is a big headache, right? Neuromas.
A major challenge. Preventing painful neuromas is tough. Surgeons try various things. Tying nerves off, coagulating them, simple division, traction then division, burying the end deep in healthy muscle away from pressure points. Early therapy like desensitization helps too. Newer elective techniques like targeted reinnervation are also emerging.
The chapter then details specific amputation levels.
Yes, from fingertip all the way up to forequarter, shoulder girdle removal. It covers techniques and key points for each level. Digits, ray, digit plus metacarpal, thumb preserve length, hand, wrist, forearm, optimal level for prosthesis, Krukenberg option, elbow disarticulation, often preferred to cutting humerus, upper arm, different prosthetic needs depending on level, shoulder disarticulation, and forequarter, most complex functionally.
What about post-op care and complications?
Standard wound care. Drains often used, early movement, compression dressings, range of motion exercises. Local issues could be infection, rare, healing problems, flap issues. Systemic issues relate to other injuries or health problems. Revision surgery is quite common, especially after trauma.
And phantom pain.
Very common.
Yeah.
Here's the majority. Can be long-term for 40–80%. Treatment is multimodal meds, surgery, psychological approaches, nerve stimulation. Losing the dominant hand might predict worse pain.
Psychosocial impact is significant too.
Very. Higher rates of depression, anxiety, PTSD compared to lower extremity amputees. Maybe 30–40% need psychological support. Physical rehab is complex too. Upper extremity prosthetics lag behind lower. Focuses on shrinking, shaping the stump, desensitization, ROM, strength, independence, prosthetic training.
Finally, Chapter 122 touches on prostheses and hand transplantation.
Right. Prostheses range from cosmetic silicone ones to body-powered cable harnesses to myoelectric muscle signals control motors.
Yeah.
Myoelectric tech is advancing, especially with targeted reinnervation improving control. Brain-computer interfaces are being researched. Hand transplantation has had successes since the 90s with better immunosuppression. But it's demanding, high-risk rejection, and its overall utility versus advanced prosthetics is still debated. Long-term outcomes data is scarce, revisions happen, prosthetic acceptance can be poor, especially for higher levels, and returning to work life is challenging. Emphasizes the need for multidisciplinary care.
Wow. That was incredibly thorough. We really have covered the breadth of upper extremity arterial disease, effectively creating that condensed Rutherford guide for surgeons.
I think so. We hit the epidemiology, the really diverse causes, which is key compared to the legs, how to diagnose these conditions, the full range of treatments from meds to complex surgery, and importantly, the difficult considerations around amputation.
And it's clear this isn't a static field. The advancements in surgery, endovascular techniques, and especially prosthetics seem to offer real hope for improving function and quality of life.
Definitely. Progress is being made.
It really makes you think, though, about where future research needs to go. Understanding those underlying mechanisms better, especially for the autoimmune and vasospastic conditions, seems crucial. And how do we better tailor rehab and prosthetic solutions to the incredibly complex functional demands of the hand and arm?
That's the critical question, and it highlights why a team approach is non-negotiable here. You need the vascular surgeon, yes, but also rehab specialists, prosthetists, pain experts, mental health professionals, all working together, especially given the profound impact this has on a person's life. It really takes a village to manage these conditions effectively.